Glioblastoma is essentially brain cancer. Sadly, it's one of those very few tumors we still haven't found a cure. And sadly, again, the survival is very short. There are tumors, there are some risk factors which come into play. One of them is.
Thank you, Professor Puneet Plaha. Welcome to the Impact Show.
Thank you very much for the invite, Surya. Very grateful.
Thank you. As a neuro-oncology surgeon, what does a typical day involves at your hospital, John Radcliffe?
John Radcliffe is a busy, big neurosurgical hospital, one of the biggest in the country. So a typical day would involve, it's very diverse. It can vary. Say if I'm on call, then it's busy. You get about anywhere up to 40 to 50 referrals every day because we cover a catchment area of about 3.5 million people.
Okay.
And it can be diverse referrals from brain tumors to trauma to everything. Then it can be busy with outpatient clinics. It can be busy with multidisciplinary meetings. And obviously, if there's an emergency, you can be busy in the operating theater all day. So I would say it's a pretty full day. Start early in the morning around 7:30 and can go until 8 o'clock at night.
Okay. So you see patients kind of every day, or you speak to them on the phone?
I see patients pretty much most days of the week. And there's a combination of face-to-face clinics and some of them are video call clinics.
Okay.
Is how we set them up.
I want to ask you to explain a few neuro-oncology diseases, but can we stick to glioblastoma?
Okay, of course.
Can you please explain what it is and the treatment options?
Yes. So glioblastoma is essentially brain cancer. Sadly, it's one of those very few tumors we still haven't found a cure, cancerous tumors. And sadly, again, the survival is very short. It's on an average about a year and a half. And over the last decade or so, there is a lot of push, certainly from NHS England and NIHR for fund research, along with a lot of other charities in the country for this particular cancer. The mainstay of treatment is surgery. A good operation where you take a significant amount of the cancerous tumor away makes a big difference in controlling the cancer, makes a difference in your prognosis and your overall survival. And then you follow it up with radio and chemotherapy to hold it off for a period of time before it sadly comes back.
Is there a grades in glioblastoma?
So glioblastoma is actually grade 4, the highest grade.
Okay.
And that's why it's one of those which is still not curable.
I want to ask you about the risk factors to develop neuro brain tumors.
So I would say majority of the brain tumors are what we call as sporadic. They happen without a known definite risk factor. However, there are tumors, there are some risk factors which come into play. One of them is radiotherapy. So if you've been exposed to radiotherapy as a child or have had radiotherapy previously in your life, then you have a risk of getting cancers later on. And they can be cancers, when I say cancer, they can be tumors like meningiomas. Sometimes they can be cancerous tumors as well. There is a small cohort of brain tumors which are hereditary, which you have a genetic change. One of them is called neurofibromatosis. You get sort of nodules and changes in your skin, and if the gene is there in your parents, you pick it up as a child. There are some conditions called, for example, Turcot syndrome, where you can get brain cancer and other cancers as well. I would say by and large, looking at other cancers in the body, brain cancers are usually don't have many risk factors to them and are usually sporadic because of a change in the brain, and very few are hereditary. They do emit radiation, but very low dose. There is no evidence to say that long-term usage of mobile phones can cause brain tumors.
Okay. How do you effectively communicate a prognosis to the patient and their family members?
Yes, no, it's a good question. I see patients with brain cancer, 2 or 3 times in my clinic every week. And sadly, one of the tasks of being a neuro-oncology surgeon is telling them for the first time they have sadly an incurable brain cancer. And it is hard to communicate when you have someone who's 18 years or 20 years and their family. And I think over the years, what I've learned is the number one thing is to be honest and straight with them. If you tell them clearly in simple terms what it means, we have surprisingly, or certainly I have surprisingly found that people cope extremely well with it. Where they find it difficult is where you are sort of beating around the bush. And we have a lot of support for them in terms of psychological support, in terms of community support, in terms of support from specialist nurses in the hospital to give them time to cope with this and deal with it. And that support continues through their journey. From the first time they see us till the end of the treatment, that support is maintained. And I think with time, because they know there's the web of support around them, the people cope very well.
About therapies, what is the best therapy from your experience for a neuro-oncology?
I think best therapy for brain tumors, well, it depends. You can have benign tumors, you can have cancerous tumors. In majority of the cases, I think it's fair to say where tumors are large, the thing which makes the biggest difference to patient and their quality of life is surgery. If they have a good operation which does not give them a problem afterwards, either a stroke, paralysis affect them, then that's the best long-term outcome for them if they recover from it. Then there are other therapies of radio and chemotherapy, but mainly for cancerous tumors, not for the benign ones. Usually not for the benign ones, although radiotherapy does play a role.
Sure.
But surgery makes a big difference.
What about rehabilitation from multidisciplinary approach?
Yeah, it's a good question again. Rehabilitation is important. So what we now do is where patients are going through a big operation, we get them seen in the clinics by the physiotherapist, occupational therapist, even before surgery.
Okay.
Why? Because they can see the patient, they can make an assessment. If someone needs support at home, for example, if they're staying alone, they need support at home, rehab at home, the team will start putting that in place even before the operation.
Okay.
They'll go make a home visit, they'll assess their needs, they'll put in rails, support at home, bathroom support, other things before the patient goes in. And then in terms of rehabilitation, I think it takes various forms. You can have physiotherapy, you can have psychological therapy, you can have speech therapy. And all these come into play, especially if you're doing operations for patients' tumors around important areas like speech, for example, where speech will get affected after the operation. You get them seen by the speech therapies beforehand, speech therapies afterward, so they can work on it. So they're all part of the rehabilitation team.
Okay.
So it takes different forms depending on what's required for the patient.
Okay. Is it definite that speech is going to be affected for all brain tumor?
No.
No.
Speech comes into play when the tumor is around the speech area. And to minimize the risk to them, we do the operation with them awake.
Sure.
So that while you're taking the tumor out, they can talk, you can assess their speech, you can try and preserve as much speech as possible. So the answer is no.
Okay.
It doesn't necessarily get affected.
You mentioned it about awake surgery. That's your specialty. Can you please explain what it is?
Yes. So awake surgery, essentially, as the name says, is basically doing an operation on someone's brain, majority for brain tumors, but they're awake during the operation. Now, we are used to doing operations whether brain or elsewhere under general anesthesia. So why awake? Because you want one patient to talk. So where they have tumors around their speech areas, there is no way of assessing that if somebody is under general anesthetic.
Okay.
So you have them awake, they are talking during the operation, and whilst they are doing this, you're taking the tumor out. Now, as you go close to the speech areas, you can modify somebody's speech during the operation by stimulating the speech area with low voltage electrical current, much lower than what you see on your general electricity at home. So it gives you clues where the speech areas are, where to stay away from, where to go. You are trying to maintain a balance between removing as much tumor as possible, because the more you take out, better for the patient. But you're also trying to find a balance of not damaging the speech. Now, in some cases, you will find the speech does get affected, but speech is remarkable in recovering with good speech therapy because you have multiple connections in the brain. So this is where your question earlier of rehabilitation and speech therapy comes in. So you do the operation, you take out as much as you can, and then patient's speech recover with speech therapy afterwards.
Okay.
So awake surgery has completely revolutionized how we operate on difficult tumors in different parts of the brain. We were doing a lot of it previously, then it went out of, people stopped doing it, but now we do it a lot because our understanding of the brain has improved. We know where to go, we know where not to go. And so it is, I think certainly in Oxford, it's pretty much a routine operation we do every week.
Okay.
Yeah, with very good outcomes.
Okay. Is there any examples of any patient agreed for awake surgery, and then when they went into the theater, the setup, seeing all of that, did they refused?
Good. I think it is very rare. Yes, the honest answer is yes. I can think of a few patients over the years where they've come into the anesthetic room and felt it very overwhelming. And in that case, we've said, okay, we won't do it awake. But I would say it's very, very rare.
Sure.
Most patients are very motivated to go through the operation because they want to do the best for themselves in trying to beat their cancerous tumor.
Professor Plaha, what is the role of advanced MRI scans in order to decide if you are taking a patient to surgery or not?
Yes. So advanced MRI scan really has revolutionized how we manage brain tumor patients. And I will mention a couple of advanced MRI sequences which have played a big role. One is called diffusion tractography imaging. So what it means is, as a surgeon, I'm keen to understand which nerve fibers are going where in the brain. For example, movement. Movement starts from top of the brain, goes down to your arm and leg. It's good to see the relationship of that, or even speech or vision, and the tumor. Where is the tumor and where are these nerve fibers? How close are they? How far are they? That helps the surgeon to decide before surgery, during surgery, how to approach the tumor, how to stay away from them. So that is one imaging that's made a big difference. The second one is called as functional MRI scan.
Yes.
As the name suggests, you're doing an MRI scan, but there's a difference in the sense that whilst you're doing an MRI scan, your brain is being mapped, and usually for speech function.
Okay.
You're keen to understand which areas of the brain have got speech, which don't have speech. All of us are different. Majority of us have speech on the left side, but whether it's on the front, whether it's on the back, there are subtle differences between us. So it's good to know so that you get an individualized map of each patient's brain.
Okay.
And then you combine the functional MRI and tractographic together, you get a complete network picture. You get this three-dimensional model, you see the tumor, you know the spatial relationship of the speech, movement, vision to the tumor. And then you can say to the patient, saying, this is where your tumor is, these are where your speech areas are, or important areas. This is what I'm going to do, this is what is at risk. That sort of discussion changes how patients then consent and perceive what is required.
Okay.
So if you then say to them, I'm going to do an awake operation, they completely understand why it is and the rationale for it. So this has completely changed how we as surgeons approach patients for surgery, plan it, and also minimize the chance of neurological deficit to patient. So the risk of affecting their speech and other things goes down because you've done all the advanced imaging.
Do you want to clear any myths or fear about neuro-oncology or any neuro diseases?
I think the myth I would clear about is, in general, surgery on the brain. We have this, when I say we, traditionally we've had this notion that, an operation on the brain is very dangerous And with most patients, when they have it done, the outcome is not good. And I think I want to change that narrative because no doubt over the past decade, things have improved significantly. When I say things, the surgical technology has improved significantly. The outcomes are significantly better. For example, the risk of death from a brain tumor operation, I tell patients, is less than 1%. The chance of giving somebody a permanent stroke or paralysis is low as well, generally speaking. So I think I just want to reassure people that if they do have, sadly, do require surgery, for example, on the brain for any reason, it can be a brain tumor, trauma, or anything else, the field has moved on significantly. Surgical outcomes have improved significantly, and patients make, I would say, remarkable recovery. And so they shouldn't put their life on hold, thinking it's an operation on the brain which would have permanent consequences and would affect them permanently. No, that's not the case. Okay. So I just want to reassure more than the myth that actually we have made significant progress in improving patients' quality of life and getting them through something like this.
Do you give any, or your team give any lifestyle advice for the patient to recover after the neuro-oncology surgery?
Yes, so I think the lifestyle advice really is difficult to coach someone in changing their overall lifestyle. But the thing we always tell them, again, traditionally we've always thought if you're having a brain tumor operation, the best way to recover is to spend a long time in bed afterwards relaxing. But that's the wrong thing to do. Now, what we've set up, for example, in Oxford and some other centers in the country, is something called the short length of stay pathway. So, for example, if somebody has a brain tumor operation today, I would say 80 to 90% of them would go home tomorrow.
Okay.
So, again, it doesn't matter how long an operation you've had, the quicker you're up and about on your feet, the quicker you go home. You go home, you're mobile at home, the better you will recover. It significantly reduces the risk of complications. So the lifestyle advice we give them is activity. You cannot change somebody's dietary intake in a few weeks or days that you see them. But certainly you can inspire them to be more mobile and more active, and they no doubt make a much better recovery.
Sure.
Bed rest, not a good thing. And then obviously other advisors come through if they've got other unhealthy lifestyles. We tell them, some of our specialist nurses give them advice as well. But that's a long-term change they have to make. It's a choice they have to do. But certainly getting through surgery from our perspective, more active, the more better you are in terms of recovering.
Okay. Thank you so much for all the insights involved in neuro-oncology surgery. Thank you so much.
Thank you for asking me.
Thank you very much.
Thank you.
Thank you.
Thank you.